Why is UTI important, and why is antimicrobial resistance important? I'm sure you've all heard this many times today, but I think this is a really interesting figure. So by 2050, there'll be more cases, more deaths caused by antimicrobial resistance than due to cancer, and diabetes, and diarrheal diseases, and road traffic accidents put together if we don't do something about it. And actually that, I think, is a very interesting figure, because often you will have been given this, oh, there's going to be 10 million deaths to AMR, but they haven't put those other deaths next to them. So why do we need to worry about our antibiotic use in suspected UTI and about preventing UTIs? Well, the rates of E. coli bloodstream infections have increased by a quarter in the past 5 years, and they're continuing to increase. And actually, the mandatory surveillance that's being done at the moment shows that actually having a previous UTI is a really important risk factor. So that suggests that some UTIs are not being treated properly. Urinary catheters, and we know, we all know that urinary catheters is a problem. But antibiotics in the previous month also indicates that are they getting the wrong antibiotic, or have they then got resistance? And then another important risk factor is older age. And that is mainly because there are many more UTIs in older age groups than any other. This is just an example of one CCG. So this is a graph, typical CCG, just showing number of antibiotics for UTI. It's so, in a way, it's the number of UTIs diagnosed and treated by GPs in a typical, GPs and nurses and others, prescribers in a typical CCG. And as you can see, in this particular CCG, there's a fourfold variation. That's, per 1,000 patients over 70 years. So this isn't anything to do with the fact that this one practice on the right-hand side has lots of elderly people. It's because it's for 70. So there's a huge variation in diagnosis. So what I'm wanting to do today is to provide evidence showing the importance of optimizing antibiotic prescribing to help control antibiotic resistance in your patients, and discuss some UTI clinical cases where we could optimize our antibiotic prescribing, suggest some strategies and share some materials, one of which is the leaflet that you've had, and the flowchart. Some of you have got the flowchart. And show the evidence for using those materials and help you develop an action plan. So the idea of the aims of this workshop are to leave you with greater capability, that's knowledge and skills, and motivation to improve the management of UTI, and give you the tools and think about how you can increase your opportunity to do so. So, the first thing is, if you could go on to, now that's interesting because this hasn't done. Okay, oh yes, so first of all, I want you to consider this scenario, okay? You've got an 80-year-old resident in a nursing home, strong smelling urine but clear looking, increasing confusion over the last 2 days, no history of fever, temperature is 37.4, and has had antibiotics in the past for suspected UTI. So I want you to reflect on what else you should ask about. So, okay, that's unfortunate that it's staying like that. Okay, so go to Mentimeter, go to www.menti.com and use the code 164172. Have you all put in your code? 164172. Sorry? Have you put in www.menti.com? Menti, not Mentimeter, menti.com. There's some people at the front who are being successful. People are successful? Okay, so have you got the first question? And what does it say? Okay, excellent. So it's working. So, okay, so I want you... Okay, so we'll go back to the question. Okay, you start putting in what else you might want to ask about. To decide what...
I'm just 5 minutes behind you. Can you code again? The code to get in.
164172. Yep. Okay. Okay, you all are happy? So you can put in more than one. You can go down the list. Don't return. Put in one word, then you can put in another word, then you can put in another one. And then press return when you put as many words as you like in. Okay? Yeah. You can put 2 words if you like. You know, it's up to you what you put in. Okay? So, an 80-year-old resident in a nursing home. So, what are you going to ask about so that you can manage the patient? Decide what to do.
Any other symptoms?
Yeah, it could be, yes. So we're going to put them up. Are you putting them into your phone? Okay. So we've got 26 people who've answered yet, and there's more than 26 in the room. Come on then, guys. You could be enthusiastic. Participate. How many people are participating? Okay, maybe I should know how many people are not participating. Then we can decide. There's only one who isn't. So 33, okay, 34. We're getting there. Okay, we'll keep going. So, it looks like we're all concerned about hydration and fluid intake. And you're all going to ask about dysuria. Some of the other urinary symptoms, you're going to ask whether they've got a catheter. Ask about other symptoms. You're going to ask about their incontinence, the news score somebody's put down, what pain they've got, whether they've got hematuria. So 50 people have now participated. Okay, so you can still participate, keep going if you want, but... and we can go back. So we've got 52. So what we need to ask about, these are some of the other things other people have asked about, is symptoms of sepsis and pyelonephritis are actually really important because we're wanting to reduce E. coli bacteremia. So we want to look at that, for signs of symptoms. We want to look for new or worsening UTI symptoms. And you said that. People talked about pain, so suprapubic pain, visible hematuria, other symptoms suggesting another infection rather than UTI, previous antibiotics, other signs of delirium, and other risk factors. So we're going to go through the flowchart in a moment to really help you which will help you look at which of those symptoms are more important. So there's a next question. You might want to go on to the next question now. Okay, so this next question is, do you use dipsticks, urine dipsticks, to help diagnose UTI?
I'm sorry, can you give me the code again? I came out of the page.
Sorry?
The code.
Oh, the code?
Yeah. Sorry.
It's the same code,
Yeah.
164172.
Thank you.
Okay, so you go to the next question. There it is. So we've got one person who's answered so far.
What if you don't agree with any of that question, any of that answers?
Do the one that's closest. It's probably for your 80-year-old lady. So, or for, an 80-year-old lady, yes. Yes. It's for this 80-year-old lady. Oh, okay. Well, do you use urine dipsticks? Because actually, it's the same whatever, It should be, we're talking about over 65-year-olds. 37 people? So it's great to see that many of you have a practice protocol. And the A2 said yes for all patients. So that's interesting. So, and A2 say no for no, never. So there's quite a disparity between those two, and only for patients with mild symptoms. So I should have said in this, it may be that some of you have put it in for all ages. So what I was meaning for over 65s, because that's what this session is all about, over 65s. Okay. So really, you can keep answering that if you'd like, because we've got 39 and we know there's more than that of you answering. Okay, so what we'd like to get takeaway messages for today. So do not use urine nitrate and leukocyte dipsticks in over 65-year-olds. Use the flowchart, which I'm going to go through to help with the management of suspected UTI, and consider postmenopausal syndrome. Think pyelonephritis and sepsis. Exclude other causes of delirium, or, consider them. Pinch me, using the acronym Pinch Me, which is really easy to think about. Always safety net. Set up nitrofurantoin as a default antibiotics unless an upper UTI. And what can you do to help and inform your process? So share the target leaflet with patients during consultations or in the care home. Do a UTI audit of over 65s. And do the free RCGP online UTI module, and use standby rather than daily prophylaxis for recurrent UTI, and review 6 monthly if you do use them. So just to get an idea, I just want to know who knows about that PHE UTI Diagnostic flowchart for over 65s, or somebody using it. So again, this is the question. There's another question, so go to the next question. Yes for all patients, only when needed to remind myself of the content. No, I've heard of it, but never used it. No, I've never heard of it. So it's really to get an idea when I go through it how many of you are actually using it, and it gives you an idea of how many other people in the room are using it at the moment. Looks like we're going to have an equal number. 28 people have answered, not patients, people. few more. There's a few of them around if you want to see them to know whether it looks like something you've been given locally. I could show it to you. This one, it looks like this. Okay, so some people have used it for all patients. Some people use it, but only use it not in every single patient. And then there's some who've, the majority probably, 2/3, haven't actually heard about it. So I'm going to go through the flow chart and just show it to you and really give you some basis for the background behind it. So obviously we're wanting to reduce E. coli, UTIs, and reduce antimicrobial resistance. And I've shown you the diagram showing that there's a 4-fold variation in diagnosis and treatment of UTIs in over 70-year-olds in different practices. So what we're wanting to do is decrease that variation and reduce unnecessary antibiotics. So the first thing is that when you have somebody presenting with suspected UTI, we don't want you to perform urine dipsticks. The reason being is that actually they're extremely unreliable because asymptomatic bacteria increases as you get older. So by the time you're 80, 50% of women will have bacteria in their urine, whether they've got symptoms or not, and you'll get a positive dipstick, whether that's the cause of their confusion, delirium, incontinence or not. So the next thing is, when you've got somebody who you've got suspected UTI, we want you to think sepsis. Now, this flowchart was done with a very large needs assessment. We spoke to over 150 healthcare professionals during the development in general practice, care homes. We also spoke to the general public of different ages and relatives of elderly patients and elderly patients. And we had an older patient on the steering group. So we looked at what they wanted from the flowchart, and we looked at the evidence for different approaches. So we've done a lot of work, and then we had a series of workshops to finalise it, and it's gone to and fro. So I'm feeling very confident that it's a robust flowchart for you to use in your practice. So first of all, we need to think sepsis. One of the feedback we had is that we can't recommend you to use one particular sepsis tool because every CCG is doing something different. That might be correct or incorrect, but it's the reality, okay, in life. So you need to agree in your CCG, find out what they're using and use that. So there may be the NICE sepsis score, the RCGP sepsis score, or the NEWS2 sepsis score. And the rationale in the flowchart on the website gives you all the details of it. Okay, then once you've excluded sepsis, you need to think of signs of pyelonephritis. So that's when you think about kidney pain, pain under the ribs, myalgia, flu-like illness, nausea, vomiting, etc. I'm not going to go through this in all that detail because we haven't got time. So, and then if you think there's sepsis or pyelonephritis, that is when you need to use the local guidance, and now NICE guidance, I'll go into that in a bit, but is now recommending cefalexin first line for suspected pyelonephritis for oral treatment. So then, in the elderly, if you've excluded those, you then think, right, let's look at their symptoms. And this flowchart is based on Loeb and another big study done by Cooper, where it's a pragmatic study in Canada as well, where they put into practice this flowchart. And also Elizabeth Beach has used this type of flowchart in care homes. in the to dip or not to dip. So if you've got new onset dysuria alone, then that is sufficient to diagnose a UTI in the elderly in the absence of other symptoms. You say, well, it's very difficult to ask older patients about dysuria. Our tip is from clinicians that what you need to do is you ask the carers, have you taken this lady to the toilet? Or have you watched them have a wee if they're incontinent? And if they have dysuria, they're going to have pain and they're going to show it on their face. So often that's something that isn't actually asked. You know, somebody says, oh, I don't know whether they've got dysuria. So it is something that can be asked. And then 2 or more of the other symptoms or signs on the flow chart. If they've got just delirium or debility, if they've just got fever and delirium debility alone, you need to consider the other infections as well. If they've got a urinary catheter, check whether it's blocked and consider removal. And then again, as I said, you need to consider genitourinary syndrome of menopause, especially in the younger 65 to 75-year-olds. Well, any of them really. Okay. So checking for other causes of delirium, the carers thought that the PHE acronym was really useful. Okay, PHE stands for pain, other infection, poor nutrition, constipation, hydration, other medication, environment changes. There's so many other causes of delirium that we need to consider. And also check for other localized symptom signs for a respiratory tract, gastrointestinal tract, or skin or soft tissue infection. And then if you consider those and you think they've got those, then you need to take that forward. And if they haven't got any of those and they haven't got symptoms suggesting a definite UTI, we advise watchful waiting. So these key messages from the Baines project, they use the UTI guidance and good hydration, avoiding acute kidney injury. And they found a 67% reduction in CCG antibiotics prescribed, a 56% relative reduction in care home antibiotics, so that's a 24% absolute reduction, 82% reduction in prophylactic antibiotics, and reduced unplanned admissions and reduced calls to GPs for inappropriate UTI. So they're using a very similar flowchart in care homes. Okay, so let's go on to scenario 2. So this is slightly different. Okay, we're going to go, just in case you've lost it, remember it's 164172. Okay, so it should still be there if you go back to your internet. Okay, so you've got an 80-year-old resident, same age. Again, no confusion, delirium. Got new dysuria, new incontinence, temperature 37.5, received antibiotics previously, EGFR 48, no allergies. So you want to know what antibiotic would you use to treat this patient, if any? Trimethoprim, nitrofurantoin, pivamicillin, fosfomycin, cefalexin, amoxicillin, ciprofloxacin, other. So have you all got your number up? 1641. So trimethoprim, pivamicillin, fosfomycin, cefalexin, nitrofurantoin, amoxicillin, coamoxiclav, cipro, or other. Interested to know what the other is? Oh, that's none maybe. Yeah. Oh, I should have said none. Okay, so let's think about the flow chart. If you've got the flow chart handy, you can have a look at it. So you've got a patient over 80 with new dysuria. So actually new dysuria alone is, and a temperature is enough to definitely treat this patient. And also they've got some, I'm not sure whether it was new confusion. Let me have a look. No confusion, but new dysuria and new incontinence. Okay, so the EGFR is 48. So there's a discussion as to when you can use nitrofurantoin in people with lower UTI. And if the EGFR is 45 or less, we should be using other antibiotics. But first line for UTI, this is the new NICE PHE guidance, suggests nitrofurantoin MR 100 milligrams twice daily for 3 days in the elderly. So it's not 5 days or 7-day course, still a 3-day course. You can use trimethoprim if the culture shows susceptible. But as there's increased resistance, you always need to safety net and advise pain relief and self-care. So why are we wanting to use nitrofurantoin? This shows the increasing resistance to trimethoprim in the over 80s. So the top line is the over 80s. So you can see it's much higher than other groups. So currently in England, in Wales, it's running at 47%, and in England it's very similar. But note that since 2015, there's actually been a significant reduction. And that's because we're changing over to nitrofurantoin from trimethoprim. This is a typical this is a PLT. It's a group. It's a Gloucester town, and this shows resistance to trimethoprim on the left. So in each of the practices, so up to 30%, but nitrofurantoin is still, very low in most of the practices. And this is comparing nitrofurantoin and trimethoprim in a typical CCG. So you need to think about and do an audit to see what you're doing in your practice. And what we're wanting is the quality premium is a 30% reduction in the number of trimethoprim items. So you might say, oh, well, of course, it's not just me, it's the hospital responsible. But actually 72% of prescribing still is in general practice in the elderly. And why is it important? We know that if you actually have taken an antibiotic, your risk of resistance persists for at least a year. So these are patients in primary care who've had an antibiotic in the past 2 months, and they've got 2.5 times of risk of resistance. And if you have resistance to trimethoprim, 36% of them will come back to your general practice in the following week. So what about delayed prescribing? So in these patients with very mild symptoms, you could consider a delayed prescription, while you're having this watch and wait. And this is 5% of over 65-year-olds in this study reported having delayed prescription in the previous 12 months. But the over 65s are split in their support. So still 40% are happy to have a delayed prescription, but many are not. So if you do use it, you need to explain. So I said that safety netting is really important. And that's where this UTI leaflet comes in. And this is very much in line with the messages on the flow chart. Dipsticks do not help if there's no symptoms. It gives you the signs and symptoms of UTI, other causes of confusion, self-care, a bit about antibiotics, when to seek help, and very much preventing UTI, looking at that hydration. Very much, again, also developed with patients and those who care for older patients. So what are we going to use second line if the eGFR is under 45 mils? So the guidance is suggesting that we use pivmesilinam, which I think is probably the first choice in these patients. So fosfomycin is not so readily available. So maybe you could put your hands up who has used pivmesilinam. Yep. Okay. So this is again a typical CCG. Actually, there's very little pivmesilinam being used, which is the yellow, in most of the practices. There's a lot of cefalexin being used, probably inappropriately for lower UTI. So the question is, have you audited how many patients, 70 plus, in your practice, this is the next question, on prophylactic antibiotics for UTI? And how often do you review them? So do you know, have you audited how many patients, 70 plus, in your practice who are on prophylactic antibiotics? We've got to be really fast here because we're running out of time, guys. It looks like most of us don't. So this is a really good audit because actually that's one of the things that Elizabeth Beach found that we could really reduce was numbers on prophylactic antibiotics. So how often do you review patients on prophylactic antibiotics? So 3 monthly, 6 monthly, 9 monthly, annually. I don't review unless the patient comes back. Okay, so the message is, the guys on the right, we need to be reviewing more often and really thinking about it. So, I love this. Don't you love this? Sorry. I'm getting quite excited. Yeah, okay. Okay. Also, it's very anonymous, isn't it? So we can do it without anybody knowing and don't feel guilty. Okay, so... so we do need to do that a lot more. So that's a take-home message. There's some people doing that. So preventing it, so with recurrence, there's several things. First of all, there's no evidence to support cranberry products or urine alkalizing agents to treat a UTI in any age group. First thing, okay, important message. Hydration, yes. Cranberry products, alkalizing agents, no. Recurrent UTI. There's some evidence with recurrent UTI that cranberry products, mostly capsules, not juice, work in younger patients. But there's actually no evidence in older patients at all. Okay? D-mannose supplements, which are actually a constituent of cranberry juice, and D-mannose reduces binding of E. coli to the bladder, does have some evidence, with only a number needed to treat of 3, that it reduces recurrent UTI. But it's a lot of sugar for older people who are diabetic. It's not prescribable and it's very expensive. So treatment of pyelonephritis, just to raise your awareness, because this is very new, it's cefalexin, first line. And coamoxiclav only if the culture results are available and susceptible. And again with trimethoprim, only if you've got culture results. And ciprofloxacin, we need to consider safety issues because there's been an MHRA warning. But actually, if you've got somebody with severe pyelonephritis, I would definitely use ciprofloxacin. Okay? Okay, I'm going to miss that one. So what other things have we got available on the Target website to help you? We've got audits on management of UTI, so you can do these audits. we've got other training resources, and there's a shorter webinar as well as these. There's also a non-medical YouTube video on using the leaflet and the diagnostic flowchart. So what I want you to do, how many minutes have we got? Oh, okay. Okay, so what I want you to look at is your action planning that you've got, and actually look at it and think, what are you going to do in your practice now to take this forward? And while you're doing that, and I also want you to fill in the evaluation sheet. But think about that because it's really important for you. How long did I have? Was it 45 minutes? 40, okay.
What was the next slide?
In your surgery. One's your surgery. Okay, so again, this is very similar to what I said at the very beginning. But what can you do in your surgery? How many are actually in surgeries? How many are in care homes? Are you all mostly in hospitals then? Or community? CCGs. Okay. Okay, well this is what you need to get your surgeries to do. Agree antibiotic choice in line with the local guidance. Agree diagnostic tests in line with the diagnostic tool and what they're going to do. Get them to laminate the diagnostic flowchart. Set up some computer reminders for the leaflets and backup prescribing, because you can set them up in the practices. Get them to do a practice audit, UTI audit. Encourage others to do the RCGP Management of UTI free online course. Stop them using urine dipsticks. And encourage the non-medical staff to watch the HEE video.
So what's the free online course, Management of UTI? What's that?
It's on the Target website. If you go to the Target website, if you Google Target antibiotics, if you go down there, there's learning resources, and on there's some Target webinars where there's one on UTI, and there's also a specific one on the RCGP website on UTIs as well.
So just a short...
It's probably about an hour, but the video is much shorter. Oh, the video is literally is very short. That's only 8 minutes.
I haven't noticed that one.
Yeah.
I haven't noticed that one.
It's only very new.